Welcome to the Platelet Couch. My name is Fazan Tatar. I'm a Senior Medical Science Liaison with SOBI North America. Joining us today for the panel discussion, I have Dr. Jim Bussell, Dr. Terry Gernsheimer, and Dr. Lamia Tolba. We're going to be doing a panel discussion today. First off, Dr. Bussell, how do you manage Doptelet dose adjustments and the risk of thromboembolic events?
Well, to me, thromboembolic events are in general, the biggest thing I worry about with TPO agents. There is a lot of debate about whether they really cause thromboembolic events at all, but to me, I've seen some in my practice. I haven't seen any with Doptelet. I've seen them with some of the other agents. I don't think it's clear that they're related to, that the platelet count is related to thrombosis. There's some data that some people espouse that high platelet counts and arterial thrombosis are linked, as opposed to venous thrombosis, which can occur at any count. So if the count overshoots, I don't worry about it particularly. I don't want to stop the dose because even though that's what the package insert says, that's a bad way to get into trouble and have the count fall too much. And if somebody has a thrombosis and they're on a TPO agent, Doptelet or other, I think it's important to keep them on the TPO agent to not let their count fall too low so that they can be fully anticoagulated and handled in whatever way is appropriate for the thrombosis. I don't know if either of the other two of you would like to add something.
Well, I think the real important point is that a lot of patients, it is the best option they have to be on a TPO agent. And so they need to continue that. I've certainly had patients who have to be on the TPO agent. And so especially now that you've got them on an anticoagulant, you've got to make sure that you keep their platelet counts safe. And so you do have to have them on both.
Yeah. Dr. Tolba, do you have anything to add?
No, it's similar. Then you need to anticoagulate the patient. Of course, rule out any provoking factors, and patient don't hang everything on the Doptelet or the TPORA because I know it's in the PI, but make sure that you don't get tunnel vision. Rule out all the other provoking factors that could be just coincidentally happen at the same time.
Okay, perfect.
Certainly antiphospholipid antibody, for example. Sure. I think that's a very good point.
Hormone therapy, stuff like that.
So for the next question, how do you talk to your patients about different treatment options for chronic ITP, specifically TPORAs? And Dr. Gernsheimer, I'll pass it off to you first.
Okay. Well, when I'm looking at second-line therapy, this is a decision-making session with my patient. So we'll go through all of the second-line therapies. But if we've now landed on a TPORA, they've decided that they don't want immunosuppression, and they've decided that they want to take something to just raise their platelet count, at least for now. I explain all three agents to them. For some patients, when I talk about having to come into clinic weekly, that's just something that's not going to work. They travel, they don't want to have to be coming into clinic. They may not live very close to where they're going to have to get that injection. And so that becomes a non-option for them. But then we have to sit down and talk about lifestyle and diet. Because between the two oral agents that we're talking about, it's going to be more difficult for some than for others. So for example, if their diet is such that it's going to be very difficult for them not to have some dairy in it, they may be eating late, or they may be somebody who always has a bedtime snack. I may then say, well, if your diet is such, we may want to avoid anything that's going to interfere with absorption. For example, before Doptelet was actually available, I had a patient who couldn't be taking the injections. It was going to be too difficult for her. And she was literally setting her alarm for 3 o'clock in the morning and getting up in the middle of the night, taking her L-Trombopag, and then going back to sleep. it also depends on how regular is your diet, how regular is your schedule. Are you somebody who maybe sometimes eating late and sometimes you're eating early and you're never really sure, and I go to my sister's house and she serves different things. So if you don't have a very regular schedule and don't have a very regular diet, it can be very difficult to actually regulate taking a medication that requires some restrictions. And so that's the kinds of things that we might talk about.
Dr. Toba, I see you're shaking your head.
So the way I talk to my patients, again, I ask about what they prefer to start with. Do you want to do something regular every day or even once a week? Or do you want to do something that lasts longer because you don't have to want to worry about it? So if someone doesn't want to take anything every day because they're not very good at remembering something, taking a tablet every day, I discuss with them the rituximab option, and they avoid surgery because the splenectomy is still on that second line therapy option to discuss with your patient. Then I go the route of rituximab infusion in the hope it works and it lasts a year. If someone doesn't want to do immunosuppression because it is the risk of immunosuppression with an ability to fight viruses and form immunity when they take vaccines is there, they don't want that, then we discuss the TBO agonist, receptor agonist. And then I give them, like you said, I explain to them all three options, what the restrictions with each one of them, and I see what they want, what's important to them in their life is really how it helps my patients really be more compliant, is because I listen to what's important to them, not what's important to me. Because we can easily tend to be tunnel vision as like, I think that's going to work for you. But the patient does not say, we may not say anything to you because they don't want to, they're not that type of patient that face or answers back or anything. And they'll be like, okay, but they're not doing what they're supposed to do because it doesn't work for them. So that's how I start my discussion with my patients.
Perfect. Dr. Bussell, do you have anything to add?
You've heard very good points from my colleagues on the panel. The one thing I'd say to imbalance, if you want to call it that, is that all three of the TPO agents are approved for very good reasons. They all work, and there are certain workarounds, let's call it, to make taking each of them a little bit easier. But by and large, in my experience, if you give patients a choice, patients starting on medication now would probably select Doptelet just because there are less restrictions and they don't have to get a shot. Obviously, I 100% agree with what you said. I mean, it shouldn't be what I think, it should be what works for them. And I've had the experience where you say to a patient, well, it sounds to me like this might be something good. And the patient looks at you like this, they stare at the floor, and it's a no-go. So you then have to say what's wrong, and sometimes you will get another 15 minutes of history that's actually crucial to understanding their case, where they didn't tell you before, even though you sort of asked about it. They just sort of, yeah, I'm fine, and blew it off. So I think discussion and soliciting the patient's opinions and finding out what they want, just as you both said, is absolutely key.
So based off your experience, how challenging is it for patients to stay compliant on food type restrictions and to understand the difference between food type restrictions and mineral restrictions?
I think if you discuss it with the patient, they are really happy to try at least. I don't like that to have to be a question. I would much rather, if possible, have it not be part of what the issues are going to be. I mean, I think we all know it's very hard to regulate our diet so much in such a way. We're all busy. It's a busy world. And to have to, constantly be thinking, I can't eat this, or this is the wrong time for me to be eating, or I'm visiting, my sister, and this is when she serves breakfast, or this is, they eat late at night, or we're going to the theater, we're eating after the theater. It's not as easy as one would think. Most of us are not on such tight, regulated schedules that we don't have to worry about those things.
Also, even if they are compliant, first, because every patient wants to do the right thing in the beginning, it falls through eventually. It's not sustainable a lot of times. It's a few months, few weeks, and then after that.
Hey, one of the things I learned quickly that you could recognize a patient that dietary restrictions would work with. If it was somebody like my father who was home for dinner every night at 6, then you could say, fine, you have dinner, no snacks after dinner, and then they take it at bedtime. They would be people it would work for. But as Terry was saying, anybody who had any kind of irregularity, there was no way they could really do that. The one thing I wanted to add is, ideally, if you have patients who are now on L-Thrombopag, and were on it before Avatrombopag became available, initially I thought, well, you would just want to change them all to Avatrombopag because it'd be so much easier. But there's a tremendous sense by the patients and by the doctors that if it ain't broke, don't fix it.
Don't rock the boat.
So I think for new patients, you'd want to try them on something easier. But I think if you have somebody who's doing well, has figured out the diet, is okay with it, then I would tend to leave them alone.
I had my first patient who was waking up at 3 a.m. to do this, but it was working, and she was happy with it, and that was great. She was an elderly patient who then had to go into a nursing home, and they were putting her L-Thrombopag on her morning tray every morning.
Oh, wow.
And suddenly everything went haywire because she no longer had control of the medication. So, you have to be thinking.
Diet.
Or exactly. They were just, and I'm sure her diet involved I'm sure they were giving her milk with her cereal. And so you've got to be thinking constantly, how are things changing? How does this person's life now look?
It is very difficult also if they have the option in the hospital because, like you said, they put everything in the tray. That patient, she had very heavy menses, bleeding continuously. So they started on oral contraceptives or hormone therapy to slow down the bleeding. And all of them were in the same cup. So not responding to the L-Thrombopag, not responding. And then they consult us, the classical hematology team, and we go in and I see the nurse put everything in one cup and give it to her. And I look in there and I'm like, is the L-Thrombopag in there? Yes. In there, birth control in there? Yes. That's why it's not working. So it's very important also to know what changed. I had a patient on it for a couple of years, and then suddenly it's like his platelets are drifting down. I'm like, what's happening here? Same thing. I was like, do you take it with food? Or he said, I usually take all my meds with breakfast. I'm like, you remember you're supposed to do this on empty stomach. He's like, oh my God, I forgot. Routines, they get too comfortable and change. So it's important to ask them all the time what changed. Mm-hmm.
To be fair, though, I would say a couple of things. I think for me, it really helped patients when I explained why they had to have a really empty stomach, because there's other medicines like thyroid. You're supposed to take on an empty stomach, but that means half an hour. So if you explain about chelation and not having the L-Thrombopag there with the calcium or iron that can inactivate it, I think that helps with the motivation and makes it easier to the extent it's possible for them to comply. And similarly, there are a few patients who, if they're getting a shot, they don't have to worry about absorption. They know they're going to get it. And especially like for inpatients, it's a lot easier to do that because then you avoid the things that the two of you were describing.
Dr. Tolba, Dr. Gernsheimer, Dr. Bussell, thank you so much for the great information and for joining me on the Platelet Couch. For everybody at home, thank you so much for joining the Platelet Couch. Please do refer to the other videos in the series as well. Thank you so much.
Doptelet, Avatrombopag, is indicated for the treatment of thrombocytopenia in adult patients with chronic liver disease who are scheduled to undergo a procedure, and in adult patients with chronic immune thrombocytopenia who have had an insufficient response to a previous treatment. Before taking Doptelet, tell your healthcare provider about all your medical conditions, including if you ever had a blood clot, are pregnant, or plan to become pregnant. Doptelet may harm your unborn baby. Tell your healthcare provider if you become pregnant or think you may be pregnant during the treatment with Doptelet. Also tell your doctor if you are breastfeeding or plan to breastfeed. It is not known if Doptelet passes onto your breast milk. Do not breastfeed during treatment with Doptelet and for at least 2 weeks after the last dose. Talk to your healthcare provider about the best way to feed your baby during this time. Tell your healthcare provider about all the medicines that you take, including prescription and over-the-counter medications, vitamins, herbal supplements. Doptelet may affect the way other medications work, and other medications may also affect the way Doptelet works. TPO receptor agonists have been associated with thromboembolic complications in patients with chronic ITP. Thromboembolic events, atrial and venous, have been reported in patients with chronic ITP treated with TPO receptor agonists. Consider the potential increase in thrombotic risk when administering Doptelet to patients with known risk factors for thromboembolism, including genetic prothrombotic conditions and acquired risk factors. Monitor platelet counts for signs and symptoms of thromboembolic events, and institute treatment promptly. Serious adverse reactions that have occurred more frequently in patients treated with Doptelet compared to placebo was headache. The most common adverse reaction, occurring in 10% or more of patients with chronic ITP, were headache, fatigue, contusion, epistaxis, upper respiratory tract infection, arthralgia, gingival bleeding, petechiae, and nasopharyngitis.